Ever felt like you're just drowning in information, especially when it comes to complex health topics? Imagine having an expert guide, someone to just distill the essence of research, articles, notes, giving you a shortcut to really being well informed.
Well, that's exactly what we're doing today. We're about to take a deep dive into your sources, a really fascinating collection covering some of the heart's less understood challenges. Our mission for this deep dive: explore a group of conditions affecting the heart's structure, its protective layers, cardiomyopathies, pericarditis, and myocarditis. We'll pull out the crucial insights, clarify the distinctions, maybe uncover some surprising facts that'll help you understand these vital areas of cardiac health.
Absolutely. And these conditions, while they're distinct in what's actually going wrong pathologically, they often share symptoms. They can present significant diagnostic challenges. So our aim is to help you understand not just what they are, but really why they matter, how they impact the heart's fundamental structure and function, from the muscle itself right out to that surrounding protective sac. Okay, let's unpack this then. Where do we start? Maybe with cardiomyopathies. Your sources define them pretty broadly as heterogeneous heart muscle diseases.
That's right. Heterogeneous is a good word because it covers quite a diverse group. Basically, these are diseases directly affecting the heart muscle. They're a big contributor to morbidity, mortality, often tied to problems with the heart's pumping, its mechanics, or maybe its electrical system. And usually, they involve the ventricles becoming inappropriately thick, that's hypertrophy, or enlarged, which is called dilatation.
Okay, thick or enlarged. And is it always just the heart itself causing the problem?
That's a key distinction. We differentiate between primary cardiomyopathies, where the issue is pretty much limited to the heart,
Yeah.
and secondary cardiomyopathies, where the heart muscle problem is actually part of a bigger systemic disorder affecting other parts of the body too. With the primary types, genetic causes are really common. And the complications, unfortunately, can be quite severe, things like cardiovascular death or progressive heart failure.
Right. Let's focus on some key primary types then, because this is where I found it got really interesting in the sources. First up, hypertrophic cardiomyopathy, or HCM. What's the story there?
HCM. It's a genetic disorder. You see this hypertrophied, thickened, but non-dilated left ventricle. And crucially, it's happening without other conditions that could cause thickening, like, say, severe high blood pressure or aortic stenosis. Now, here's the really striking part. HCM is the most common genetic heart disease.
The most common genetic one. Wow.
Yes, and maybe even more sobering, it's the most frequent cause of sudden cardiac death in young people, including athletes sometimes.
That's quite shocking. Young, seemingly healthy people. How does it cause such risk?
Well, the thickening can sometimes physically block the blood flow out of the left ventricle. That's outflow obstruction.
Yeah.
It also significantly increases the risk for atrial arrhythmias like atrial fibrillation and also thromboembolism, blood clots. Diagnosis usually relies on ECG and cardiac imaging. Echocardiography is the most common tool used.
Okay, so that's HCM, thickening. What about the opposite in a way? Dilated cardiomyopathy, DCM.
Right, DCM. This is actually the most common type of cardiomyopathy overall if you look at all types together. And here, instead of thickening, the left ventricle becomes dilated, enlarged, and its systolic function, its ability to pump effectively, is impaired. This happens without the abnormal loading conditions or significant coronary artery disease that might otherwise explain it. And here's a really critical point for you from the sources. Idiopathic DCM, where we don't know the exact cause, is the primary indication for cardiac transplants in the U.S.
The number one reason for transplants. That really underscores its severity.
It does, and the causes. They're incredibly varied. There's a familial link in about 25–35% of cases. It can also happen after myocarditis inflammation of the heart muscle, which we'll get to. Sometimes that initial myocarditis might have even been asymptomatic from the patient's perspective. Other causes include alcohol abuse, certain chemotherapy agents, and various systemic disorders. It's a wide net.
Okay, a really wide net. What about arrhythmogenic right ventricular cardiomyopathy, ARVC? That sounds quite specific.
It is. ARVC is characterized by the progressive replacement of the heart muscle, particularly in the right ventricle, with fibrous and fatty tissue, scar tissue, essentially. There's an area often called the triangle of dysplasia where this commonly happens, but we're increasingly recognizing it can affect the left ventricle too. It presents a whole spectrum of issues, from sort of subtle ECG changes, maybe nothing much felt by the patient, all the way to life-threatening ventricular arrhythmias, heart failure, and sudden death.
So, the muscle itself is being replaced, and then there's left ventricular non-compaction. That sounds unusual.
It is quite unique. It's marked by this spongy appearance of the myocardium, the heart muscle. The thinking is that it's due to an arrest, a stop, in the normal development process of the heart muscle during embryogenesis. So it doesn't become compact like it should. It mostly affects the apex, the sort of pointy bottom part of the left ventricle. And like the others, it carries risks of dysrhythmias, including sudden death, and also an increased risk of blood clots forming in those sort of spongy crevices.
Fascinating. And the last one in this group, restrictive cardiomyopathy, RCM.
Right, RCM. This one's defined by stiff ventricles. They resist filling properly during diastole, the relaxation phase. Often, the diastolic and systolic volumes might be normal or even reduced, and the wall thickness can be normal too. It's about stiffness, not necessarily size. It can be idiopathic, familial, or linked to systemic disorders like amyloidosis or sarcoidosis. A really key challenge here is distinguishing RCM from constrictive pericarditis, which involves the sac around the heart. Sometimes that needs specialized tests like cardiac catheterization to tell apart.
Okay, speaking of the sac around the heart, let's shift focus now from the muscle to that protective outer layer, the pericardium. We're talking about pericarditis, right? Inflammation of that sac.
Exactly. Pericarditis is simply inflammation of the pericardium. The acute form means new onset inflammation, usually lasting less than, say, 4 to 6 weeks. Clinically, it's often characterized by a classic triad, chest pain, hearing a specific sound called a pericardial friction rub, and particular changes seen on serial ECGs over time.
And how common is this? Is it something ER doctors see often?
It's actually a well-recognized cause of chest pain. Your sources mention it's reported in about 5% of patients who come to the emergency department with chest pain that isn't caused by a heart attack, so non-ischemic chest pain. And what's interesting is, well, maybe 80–90% of cases get labeled idiopathic, meaning we don't pinpoint a specific cause.
Right.
The thinking is that the majority are probably viral in origin, and they're often self-limiting. They get better on their own, especially in younger, previously healthy adults in developed countries.
Okay, so the symptoms. You mentioned chest pain. How is it different from, say, heart attack pain?
It's typically quite distinct. The pain is often constant, sharp, and pleuritic, meaning it gets worse when you cough or take a deep breath or lie flat. And classically, it's relieved when the person sits up or leans forward. That's a big clue.
Right.
And there's this other highly specific feature you mentioned from the sources, pain radiating to the trapezius ridges, the tops of the shoulders.
Yeah, why there?
Because the phrenic nerve, which carries pain signals from the pericardium, also happens to innervate those muscles. So the brain sometimes gets the signal mixed up. It's quite specific for pericarditis. And then on examination, you might hear that pericardial friction rub. It's this scratchy sound, kind of like leather rubbing together, timed with the heartbeat. That's a key finding.
Okay, so the leaning forward helps, pain to the shoulders, maybe a rub. How is the diagnosis confirmed?
Diagnosis of acute pericarditis is generally confirmed if someone has at least 2 out of 4 clinical criteria. Those are, number 1, the characteristic chest pain we just described. 2, hearing that pericardial friction rub. 3, seeing widespread ST segment elevation or PR depression on the ECG. And 4, finding a new or worsening pericardial effusion fluid around the heart on imaging.
And the ECG changes, I gather they can sometimes look a bit like other things?
They can, yeah. Sometimes it can be confused with a benign pattern called early repolarization. But one useful distinguishing feature your sources note is looking at the ratio of the ST elevation height to the T wave height in lead V6. If that ratio is greater than 0.25, it points more towards pericarditis.
Okay. Now, this inflammation, it sounds painful, but can it lead to more serious problems?
It definitely can. One common complication is a pericardial effusion. That's just an accumulation of fluid in the pericardial sac caused by the inflammation. Usually it's small and doesn't cause problems. But if the fluid accumulates very rapidly or a large amount builds up over time,
Then it starts squishing the heart.
exactly, it can exert enough pressure to cause cardiac tamponade. This is a life-threatening emergency. The pressure prevents the heart chambers from filling properly with blood during diastole, which severely decreases cardiac output. You might have heard of Beck's triad, distended neck veins, muffled heart sounds, low blood pressure. But that classic triad isn't always present. So if tamponade is suspected, an urgent echocardiogram is crucial to see the size of the effusion and its hemodynamic effect, how much it's impacting the heart's function.
Urgent echo. Got it. Are there longer-term issues, too?
Yes. Another serious, though thankfully relatively rare complication is chronic constrictive pericarditis. This is where over time, perhaps after recurrent or smoldering inflammation, the pericardial space gets obliterated and replaced by thick, dense scar tissue. This scar tissue essentially encases the heart like a rigid shell, severely interfering with ventricular filling. It's something to suspect in patients who develop signs of right heart failure like leg swelling, liver congestion, without a clear explanation, especially if they have a history of pericarditis or cardiac surgery. The definitive treatment for a constriction is pretty major surgery, a pericardial resection or pericardiectomy, to remove that scarred sac.
Wow. Okay. So the pericardium can cause major issues. Now, you mentioned earlier that myocarditis, inflammation of the heart muscle, can sometimes go along with pericarditis and can lead to DCM. Let's connect those dots.
That's a perfect connection to make. Yes, myocarditis is inflammation of the myocardium itself. It often does accompany pericarditis, sometimes called myopericarditis or perimyocarditis, depending on which seems predominant. And as we touched on with DCM, myocarditis is recognized as a common precursor or cause of dilated cardiomyopathy down the line. It's really a syndrome that can result from a whole host of things. Infectious agents are very common. Viruses like influenza, Coxsackie-B, adenovirus, even HIV. Globally, the protozoan parasite causing Chagas disease is a major cause, but it's not just infections. Bacteria, fungi can do it. And then there are non-infectious causes like toxins, certain drugs, including some cancer therapies, and systemic autoimmune diseases like lupus or sarcoidosis.
That's a huge range of causes. So, how does someone with myocarditis actually present? It sounds like it could look like almost anything.
It really is a clinical chameleon, which makes it challenging. Patients are often, though not always, younger, say under 50, a history of a viral prodrome like flu-like symptoms, fever, muscle aches, maybe 2 or 3 weeks before the heart symptoms start is pretty common, maybe reported in up to half of cases. The symptoms themselves can include chest pain, which might mimic pericarditis or even a heart attack, dyspnea, shortness of breath, fatigue, palpitations, very nonspecific sometimes.
Okay, so super varied presentation. How on earth do doctors diagnose it then, especially in an emergency setting? Is there like a single blood test or scan?
And that's perhaps the most crucial insight about myocarditis diagnosis for you. There is no single diagnostic test available in the emergency department that will definitively confirm or rule out myocarditis. The ECG often shows nonspecific ST segment and T wave changes. But importantly, unlike an acute MI, these changes usually do not follow a specific coronary artery territory. They're more diffuse. Cardiac biomarkers, like troponin, which we associate with heart attacks, can be elevated maybe in 30% to 70% of patients. But here's a surprising finding. Unlike in acute coronary syndromes, in myocarditis, that troponin elevation by itself is generally not associated with a worse outcome.
Really? That's counterintuitive.
It is. It suggests the mechanism of injury is different. Echocardiography is absolutely crucial, though, to look for ventricular dysfunction, wall motion abnormalities, or even pericardial effusion.
Okay, so the outlook, the prognosis.
Yeah,
It sounds like it could go either way.
very much so. The prognosis for myocarditis is quite variable. It can range from complete resolution back to normal heart function, to the development of chronic dilated cardiomyopathy and heart failure, or unfortunately, even early death in some cases, particularly with what's called fulminant myocarditis, which presents with severe shock.
So what's the absolute bottom line for someone presenting with symptoms that could be myocarditis, even if they seem okay at first glance?
This is a critical safety message from your sources, and it's worth repeating. Patients suspected of having acute myocarditis should not be discharged home from the emergency department, even if they appear physiologically stable. The potential for rapid deterioration or serious arrhythmias exists. Treatment is largely supportive, managing heart failure symptoms, treating arrhythmias. In severe cases, it might involve aggressive cardiorespiratory support medications to boost heart function, or even mechanical circulatory support devices like ECMO or VADs.
That's a really important point about not discharging. Okay, let's pull back a bit and talk about some of the advanced interventions mentioned. For severe dilated cardiomyopathy, perhaps resulting from myocarditis or other causes, your sources mention left ventricular assist devices, LVADs. What are these exactly?
Right, LVADs. They fit into the picture for very advanced heart failure, often when the heart muscle is severely weakened, like in end-stage DCM. These are sophisticated, surgically implanted mechanical pumps. They essentially take over or assist the work of the failing left ventricle, pumping blood from the ventricle into the aorta. They're most commonly used as a bridge to transplant, keeping someone alive and bettering their condition while they wait for a donor heart. Sometimes they're used as destination therapy if someone isn't a transplant candidate.
Okay, implanted pumps. Now, what was that surprising fact about them you mentioned?
Ah, yes. This is a fascinating clinical point, really connects to the bigger picture of how these devices change physiology. Many patients with modern continuous flow LVADs may not have a normal palpable pulse
No pulse. How does that work?
because the pump provides continuous flow rather than the pulsatile flow of a normal heartbeat. So you might not feel that distinct speed at the wrist or neck. Their blood pressure is often measured using Doppler ultrasound over an artery, listening for the flow, rather than a standard cuff. Those special protocols exist. It's something emergency responders and clinicians need to be acutely aware of. And another vital safety note tied to that. Chest compressions are generally contraindicated, not recommended, for an LVAD patient who becomes unstable. There's a significant risk of dislodging the pump's inflow or outflow cannulas inside the body, which could be catastrophic. Specific LEAD emergency protocols exist.
Wow. No pulse, no standard CPR. That's critical information. Okay, switching back to pericarditis, what about the frontline management for the more common, uncomplicated cases?
For straightforward acute idiopathic or viral pericarditis, the first-line treatment really focuses on symptom relief and reducing inflammation. That typically involves NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or indomethacin, usually at relatively high doses initially. And because high-dose NSAIDs can irritate the stomach, they're often given along with a proton pump inhibitor like omeprazole for gastrointestinal protection.
Makes sense. And wasn't there another drug mentioned as being particularly helpful?
Yes, absolutely. Colchicine, it's an anti-inflammatory drug that's been used for gout for a long time, but studies have shown it's very effective for pericarditis. It's now strongly recommended as a first-line adjunct therapy, meaning used in addition to NSAIDs. Why? Because colchicine has been clearly shown to improve the response to treatment, significantly decrease the rate of recurrences, which can be a real problem with pericarditis, and increase overall remission rates. It's typically given for about 3 months for a first episode. Your sources also noted an emerging treatment, rilonacept, which is an interleukin-1 trap. It blocks a specific inflammatory pathway and has been approved in the U.S. specifically for recurrent pericarditis, offering hope for those more difficult cases.
Okay, colchicine for 3 months alongside NSAs for most first cases. Good to know. All right, we've covered a lot of ground here, so let's try to synthesize this. What does this deep dive into cardiomyopathies, pericarditis, and myocarditis really tell us?
I think it tells us that heart problems are much more diverse than just blocked arteries, which tend to get a lot of the focus. We've seen how the heart can be challenged by issues with its fundamental structure, the muscle itself, like in cardiomyopathies, or problems with its protective casing, the pericardium, leading to inflammation or constriction, or when the heart muscle becomes inflamed directly in myocarditis. Understanding these distinctions, how they present, and their potential severity is just crucial.
Yeah, it really highlights the complexity.
Absolutely. And the interconnectedness, right? How myocarditis can lead to DCM, how pericarditis and myocarditis often occur together, how RCM needs to be distinguished from constrictive pericarditis. It underscores the incredible intricacy of our cardiac system. Each condition, whether it's a hidden genetic issue like HCM or this insidious inflammation in myocarditis, really reminds us how vital it is to understand these often less talked about conditions.
Yeah.
They really demand attention to detail, both from clinicians and, for all of us in understanding our own health.
Definitely. And maybe a final thought for you, our listener, to chew on as we wrap up. We heard about these seemingly small, very specific details, like pain radiating to the trapezius ridge being a clue for pericarditis, or the lack of a normal pulse in an LVAD patient being expected. If these subtle things can be such critical diagnostic or management clues, it makes you wonder, doesn't it, what other subtle aha moments are just waiting to be discovered across the vast landscape of medical knowledge, just by paying closer attention. It really shows that sometimes focusing on those small details can make all the difference in understanding ourselves and the incredibly complex world around us, especially inside us.